including the recent hurricane response in Jamaica, providing firsthand insight into the evolving humanitarian impacts of climate-related disasters. And I can say firsthand that Nadine is usually on the front lines of any response championing SRH in all aspects of it. And then lastly, but not least, we'll be hearing from Suhaila Aboud. Suhaila is a clinical officer and counseling psychologist. She currently serves on the UNFPA Global Emergency Response Team as a clinical management of rape and mental health and psychosocial support, or MHPSS specialist. She brings 19 years of experience in humanitarian and development context as a frontline health worker, providing SRH services, including care for survivors of GBV and intimate partner violence. Suhaila has supported over 30 UNFPA supported countries globally in scaling up their clinical management of rape programming during climate related crises such as floods, droughts, and earthquakes, as well as during disease outbreaks. She is currently deployed to the Democratic Republic of Congo to scale up clinical management of rape and integrated MHPSS into SRH and GBV interventions in the ongoing Ebola response. Prior to her work with UNFPA, she spent a decade with Médecins Sans Frontières in Kenya, caring for survivors of violence. She holds a Master of Science in Health Management alongside advanced qualifications in global reproductive health, psychology, and clinical medicine and surgery. And similarly, I can say when I have been lucky enough to travel to different contexts with International Medical Corps and work with our teams on clinical management of rape care, the person who has gotten things off the ground in countries and done trainings via UNFPA is almost always Suhaila. So we are really, really lucky to have this amazing panel with us today. They really are on the forefront of protection and climate research and programming. So with that, I will hand over to Dr. Lesso. And yeah, thank you very much.
Thank you so much, Lauren. Let me share my slides. All right, I believe you can see my slides now.
Yes.
So good morning, good afternoon, or evening, everyone. I know you are joining from different time zones, and I am very glad to be with you. I want to sort of begin with a simple reality. As you know, in a climate emergency, there may be no someone else who handles sexual and gender-based violence. You know, sometimes the person standing between a survivor and no care at all is you. And so today we're going to talk about what post-rape care looks like when the usual systems are broken down. You know, there's no functioning lab, there is no reliable pharmacy, no private room, maybe no safe police response, and no dependable transport. And the question, I think, for this session is not what would ideal care look like? It is what is the safest, most effective care I can still provide right now in this context. And as you've heard, I am Dr. Munala. I've spent more than 15 years researching gender-based violence, particularly in the East Africa context. And my current work looks at climate-related disruption, which can, of course, intensify risk and complicate access to care. I've also worked with healthcare practitioners in Kenya to understand the barriers they face in delivering post-rape care. So I'm speaking to you today not only as a researcher, but someone who has listened closely to providers working in the kinds of settings we are hopefully discussing today. And my goal is that you leave this session with a small number of actions that you can use when the system around you is not functioning as it should. So you can see from the formal learning objectives on the slide, but let me translate them into what I want you to be able to have at the end of our time together. First is to recognize and ask about sexual and gender-based violence safely, even when privacy is limited. Second is to respond in a way that helps the survivor feel believed, supported, and in control. And third is to start the urgent clinical care even when the lab, the pharmacy, or usual workflow is disrupted. And then fourth, build it the safest referral and follow-up plan possible when the formal system is weak or absent. So notice what I'm not going to do today. I am not going to give you a lecture that assumes a fully stocked hospital with the lab down the hall and every specialist available. We are going to work from a different question in this lecture. What still works in a camp or in a shelter or in a clinic, and perhaps with no electricity? And that's the mindset we should have for the rest of this session. So this slide captures the reality shift, I think. On the left is the environment that many clinical protocols quietly assume. You assume privacy, you assume a lab or a stocked pharmacy, you assume having electricity, you assume having police that are reachable. An ambulance or transport, and having a referral system that actually works. So now look at the right side of the slide. After a flood or during a drought or in a displacement setting, the private room may be a curtain or a corner. The lab may be inaccessible. The pharmacy may be closed. The power may be intermittent. Police may be hours away or may be unsafe to contact. Transport might not exist. Referral systems may be broken. So what remains in this context? You, the clinician, the survivor in front of you, and the basic protocols and judgments that you carry with you. So this is not hypothetical. In my recent research in Kilifi County, Kenya, adolescent girls described how, because of drought, ordinary tasks would become dangerous, right? One of the girls explained that when water becomes scarce, having to travel a longer distance to fetch it, sometimes alone, increasing the risk of sexual violence along the way. And so this is the environment in which these protocols have to survive in. And so for the next several slides, I want you to keep one fictional patient in mind. Let's call her Amina. Amina is 22. Flooding has displaced her family. She's staying in a temporary shelter, and she tells you she was sexually assaulted 2 nights ago. The nearest fully functioning hospital is several hours away. And so as we move through the next few slides, keep asking yourself, what can I still do for Amina today? So as I mentioned, picture Amina in that shelter. There are people moving in and out. There is no private room for examination, and maybe the person that brought her is sitting only a few feet away. And you have reason to be concerned about violence. And what do you do? So the answer is not, I cannot screen because I do not have perfect privacy. The question becomes, what is the safest version of screening I can provide, right? Start by asking routinely at safe touch points, during antenatal care or postnatal care, during family planning, or another moment when you can speak briefly with the patient. Keep the questions brief and low stigma. You might ask, has anyone hurt you or touched you in a way you do not want? Or are you afraid of anyone where you're staying? So the goal here is to create relative privacy. Again, you can't guarantee privacy, so creating relative privacy, lowering your voice, turning your body, use a trusted colleague as a door watcher if that's appropriate, or say and safe. Pay attention to what is happening non-verbally. A survivor may not disclose immediately. She may be watching the door, protecting part of her body, maybe showing discomfort when someone approaches. If she does disclose, document only what is necessary and safe, especially if the records are not secure. So the principle here is do the safest possible version of the right care. Okay, so now imagine Amina quietly tells you, yes, something happens. Before we go any further, think of the first sentence you would say to her. The first response matter. The World Health Organization LIVES model gives us a simple structure, right? L is listen. Give her your attention. Do not interrupt. Let her tell you what she wants to tell you in her own words, at her own pace. Inquire about needs and concerns that she may bring to you, and ask only what you need to know for care. You are not investigating the assault in this case, you're just providing clinical care. Validate. This is the step I want you to remember. I believe you. This was not your fault. Thank you for telling me. Enhance safety. Ask something immediate and practical. Where would you feel safest tonight? And S is support. Connect her to whatever safe help exists, either a community health worker or a women's group or a trusted protection actor or another resource in that setting. And if you remember only one part of this model, remember the validation part. So I'm going to give you about 10 seconds to look at these two columns. Notice the difference. The phrases on the right can communicate doubt, they can communicate blame, they can communicate judgment. Are you sure? Why didn't you fight back? Why didn't you report sooner? The phrases on the left do something different. They return dignity and control. I believe you. This was not your fault. What do you need right now? Trauma-informed communication does not require special equipment. It begins with how you make the survivor feel in the room. A survivor may not remember every clinical question you ask. They might not remember very clearly different details. But she will remember very clearly whether she felt believed, whether she felt blamed, whether she felt rushed or safe. So do not become another person that judges the survivor. So this slide is at the heart of the clinical section, but I don't want you to memorize every line on it right now. I just want you to notice the pattern. In a functioning system, we often test, confirm, document fully, and then refer through established pathways, right? In a disrupted system, waiting for an ideal condition may mean the survivor receives nothing. And so these are sort of 4 rules to carry with you. If you cannot test, just presume that, there's something there. If you cannot confirm, treat. If you cannot complete everything today, start with what is time sensitive and then document what comes next. And if you cannot refer perfectly, you build the safest link that you can, right? So now let's apply that to our fictional character, Amina. Amina tells you the assault happened 48 hours ago, right? What should immediately start running in your head? There are sort of two clocks here. Emergency contraception within 5 days and HIV PEP within 72 hours. So those are sort of two numbers to remember after this session. For emergency contraception, do not let the absence of a lab or exam delay hinder you. Use the appropriate option available in your setting and follow the protocol on the slide. For PEP, we know the key message is the same. Do not wait for the system to become perfect before starting time-sensitive protection. If baseline testing is available, it can be done as part of care, but your original protocol here emphasizes that treatment should not be delayed while waiting for a result. The medication names and regimens on the slide here are for your reference. You all are nurses, so I do not need to spend the time reading the drug names to you. But what I want to emphasize is the decision point, right? Recognizing the window and acting. Missing infrastructure should not become the reason for missing that window to act. So now imagine the lab is not functioning. Do we send Amina away and tell her to come back when testing is available? Obviously not. The approach on this slide is presumptive treatment, as I mentioned in the previous slide. The specific regimens are on the slide for your reference. Again, I won't belabor you with reading the medication and doses allowed, as you are clinicians and know this. What matters for this training is the clinical mindset, as I said. Do not let unavailable testing turn into no treatment at all. And in a displacement setting, feasibility matters. If a regimen depends on multiple doses over several days, think carefully about whether the survivor can realistically complete it, and then use the options in your protocol accordingly. And the goal is simple: same-day protection when possible. So vaccines give another useful principle, prevention now, completion later. In a climate-affected setting, flood water, soil exposure, injuries, displacement, and blood exposure can all complicate risk, right? You might not be able to guarantee that the entire system will be available next week or next month. But when a vaccine is indicated, you can start what is appropriate today and then document it clearly so that you can continue later. This is one reason documentation still matters, even when a system is disrupted. Again, start what you can and then document what comes next. So in this context, Amina wants care, but there's no formal rape kit available. Does that mean we document nothing? Of course not. You can still document meaningfully with the survivor's consent, of course, and within the limits of what is safe and feasible in your setting. That may include a body map, a factual written narrative using the survivor's own words, or other documentation that is appropriate and secure in your context. If photographs are considered, the question is not only, can I take a photo, but also, can I protect this image? If you cannot store it safely, do not create another source of risk. And I think it's important to be clear what you cannot do. If the formal chain of custody process is unavailable, do not pretend that it exists. Minimal documentation is still meaningful documentation. Again, consent first, safety first, document what you can accurately and securely. So now Amina tells you she can't return to the shelter tonight. Police are far away and she does not feel safe contacting them. There's no ambulance. Now what? And this is where I think referral becomes less about handing someone a phone number and more about building a workable next step. If police are unsafe or unreachable, obviously do not force a survivor into a referral that increases the danger. Ask them who they trust, if there's someone safe that can accompany them. If there's no shelter, maybe just a safety plan for the immediate night. The question may be, where would you feel safest tonight? Even if the option is not perfect, where do you feel safe tonight? If there's no transport, this is why relationships with community health workers, trusted drivers, local protection actors matter before the crisis occurs. If phones access are unreliable, make the follow-up point maybe a physical point and concrete. Come back on market day. I'll be here. Think about your own setting. If your normal referral system disappeared tomorrow, who is your one person that you can contact to sort of help in situations like this? If you cannot immediately name a person right now, that's an action item to take away from this lecture. A referral network just begins with one trusted person and one clear follow-up point, and then it builds from there. Climate-related displacement does not create the same risk for everyone, right? Some patients face additional barriers to safety, to consent, communication, or access to services. For minors, know the local consent and safeguarding requirements before a crisis occurs. If the caregiver may be the person causing harm, your safety planning cannot assume that sending the child home is protective, right? For displaced women, think about language, think about unfamiliarity with services, the fear of authority, the loss of community networks. Something as simple as a clear map with written instructions or a trusted contact can matter in some contexts. For people in the LGBTQI community, do not assume that the family, that the partners, that shelters or authorities are automatically safe. So using neutral language, protecting their confidentiality, asking them who they trust. And your job is not to be the expert on every population. Your job is just to know when you need additional expertise and who that person is that you can call. So this brings us to preparedness. What we do know is that the worst time to figure out who your gender-based violence advisor is, or who your child protection contact is, or which community group survivors trust is during the emergency, right? Pre-identify those people, save their contact information. Know which community-based actors already have trust in your communities. If they're women's group, if they're community health workers, if they're protection teams, if there are other local leaders who are appropriate to your setting. And then consult when the situation exceeds your expertise. You don't need to know everything yourself, right? Build those relationships for the next emergency. So before I finish, I want to change direction for a moment. I think we have spent most of the session talking about what survivors would need from you. And I want to spend a little time talking about what you need. We know that repeated exposure to stories of trauma, to stories of violence, to stories of loss, to stories of suffering can affect providers. You may notice exhaustion, you may notice irritability, difficulty sleeping, hopelessness, numbness, detachment, having the dread about work or having just physical symptoms. The important thing is to recognize those signs rather than normalize them until you're completely depleted. Your safety and well-being are part of safe care. A provider who is overwhelmed, unsafe, or exhausted cannot carry out an unlimited burden. So protecting survivors also requires protecting the people who care for them. So what does this look like in practice? Debriefing with a trusted colleague after difficult cases, using peer support and provider networks, setting boundaries about what is yours to carry in terms of emotionally and what is not. Taking breaks when you can. Obviously, that's not always possible. Pay attention when your body and mind are telling you that you have reached the limit. And then know when you need additional support yourself. And none of this means caring less. It just means creating enough capacity to keep doing the work safely over time. So caring for yourself so that you can keep caring for others. So we started today with the difficult reality, in a climate emergency, there may not be someone else that will deal with sexual gender-based violence. So what you can still do is key when the system around you is failing. First is screening. Even without perfect privacy, ask safely, routinely, briefly. Again, validate, I believe you, this is not your fault. Then treat. Do not let missing infrastructure turn into no care. Act fast. Again, remember the time-sensitive windows for emergency contraception within 5 days, PEP within 72 hours. And then build one link. One trusted person, one clear follow-up point can be the beginning of a referral network. So you may not be able to rebuild the lab. You may not be able to reopen the pharmacy. You may not be able to make an ambulance appear in that context, but you can believe the survivor. You can recognize a time-sensitive window. You can start that care that is possible. You can document safely. You can create one safe connection to what comes next. And that is meaningful care even in a disrupted system. Now, I have included the references for today's session here, including the work in Kenya on climate change and violence. I want to thank you for your time and the work you do in the settings where the ideal resources are not available. And I hope that the question that you carry forward is not only what is missing in this context, but what safe, meaningful care can I still provide right now? And so I'm going to hand it over back to Lauren, who will take us to the next session.
Thank you so much, Dr. Lesso. That was amazing, and I really appreciated such a practical approach to things, and also considering the experiences of survivors and the caregivers, which we're thankfully going to be diving deeper in a few weeks into self-care and caring for the caregivers as well. So thanks for raising that. I'll hand over now to Nadine, who's going to go through our first case study. Nadine?
Yeah, thank you. I'm waiting for the presentation. Here we are. Okay, next. Thank you. Next slide, please. So when we think about a hurricane, an earthquake, or a flood, we tend to think first about the obvious consequences, which are the injuries, the damaged health facilities, disrupted electricity and water, shortages of medicine, and people being displaced. But there is another reality which is maybe a bit less visible. Climate-related disasters can fundamentally change the environment in which women and girls live, sleep, move around, and seek care. And I will be using women and girls, but of course that applies to other people of different age, sex and sexual orientation and gender diversity. But I will use mainly women and girls in that presentation. And when the systems around them are disrupted, the risk of sexual violence, intimate partner violence, sexual exploitation, and other forms of violence can increase. So today, rather than talking about this only in theory, I would like to take you to two places, Mozambique after Cyclone Idai and Jamaica after Hurricane Melissa. There are two very different contexts where I deployed just a few days after the event. I think it was 4 days for Mozambique and 1 week for Melissa. And I would like us to look at both through one question. What happens to protection when the systems around people start to collapse? Next slide. So let's start with Cyclone Idai in Mozambique, and that was in 2019. Idai brought devastating flooding and destruction. In the affected areas, homes were severely damaged or completely under the water. In some places, the water rose several meters. Roads and communication systems were disrupted, and the landscape was transformed. Communities became isolated, and in fact, the entire area was formed on very little islands surrounded by water, and people were cut off from the rest of the country. The health services were also severely affected. The roofs in particular were stripped from facilities, and because there was huge rains, the wards were damaged from the drugs, the material, and everything. And the health workers themselves were dealing with the consequences of the disaster. Most of them had lost their home. But when we think about protection, we need to look beyond the immediate physical damage. A disaster does not only destroy the infrastructure, it disrupts the systems that normally make every life safe. So in that particular case, people were displaced, and in many cases actually, far from their home, after being rescued by helicopters for many of them. And during the rescue phase, a lot of families were separated in the process. So the result is that people found themselves in an unknown environment with unknown people, without anything except what they were wearing that particular day when they were rescued, in overcrowded conditions, and often with inadequate wash facilities and very little to no privacy. And the social and protection mechanism that normally help people stay safe were no longer functioning in the same way. So the question is not only where is the health facility, it's also where is safety, and perhaps equally important, how do I meet my basic needs? Next slide. If we look at Jamaica now, you jump one slide. Yeah, thank you. I'm sure it will move to Jamaica at some point. If we move to Jamaica, what struck me in Jamaica was something that I think is particularly important when we talk about protection. Many houses had been severely damaged, but the walls were still standing for the most part. But there was no more roof, no more doors, no more windows. And yet, many families choose to remain in their homes rather than move into collective, organized, safe shelters. Why would people stay in seriously damaged houses when shelters organized in school and other public buildings also provide food, water, basic items, and services? When you talk to people, they raised concern about their privacy, sharing space with people they don't know, and the perception of not being safe in those safe shelters. So they didn't want to leave behind the little that remains in their possession either. And sometimes simply the desire to stay close to their home, their family, their community, and what they know. That's what was bringing to them, this perception of safety. So in the case of Jamaica, in fact, the shelters closed quite rapidly because people didn't want to stay there, except those who had lost absolutely everything and who had no family where they could go. So we need to be very careful about making assumptions of what is safe and what safe means. A shelter is not automatically perceived as safer, while a damaged home is not necessarily a safe home. So for many families, there may be simply no good solution. Next slide. So as you can see in these two examples, a disaster removes the layers of protection. A disaster, think about all the things that normally provide a degree of safety. A home, having a roof on top of your head, having a door that closes, privacy, lighting, an income, family and community support, social protection. All these layers can be weakened or disappear following a climate-related disaster. And when several of them disappear at the same time, women and girls become much more exposed. If your house no longer has lockable doors and windows, you have lost physical security and privacy. If there is no electricity in town, there won't be street lighting, and you will feel less safe moving around when it gets darker. If you lost your livelihood and your possessions, you become more dependent on others for food, for water, for basic needs, so for survival, basically. And when people lose their usual means of coping, they take risks. They become more vulnerable, and some may resort to negative coping mechanisms, including exchanging sex for basic needs such as food, shelter, or protection. And if the systems that normally provide protection are also disrupted, there are fewer people or services to turn to. So the hurricane itself does not necessarily cause the violence. It doesn't make people violent, but it creates an environment in which the risk of violence and exploitation increase. And that distinction is quite important because it tells us also how we intervene. Next slide. Now I want to change the perspective without trying not to repeat what was said before and what Suella will say after. But let's stop looking at the disaster from above. Let's imagine the health worker, because eventually someone walks into your clinic. A woman arrives. She may be pregnant. She may come for antenatal care. She may have abdominal pain. She may have bleeding. Or she may ask for contraception. She might have some STI symptoms. Or she may simply say that she's not sleeping well and she doesn't feel comfortable. She doesn't feel well. And you know that she has just lived through a disaster because you are there. Her home may have been destroyed. She may have lost her income. She may be dependent on humanitarian assistance or somebody for food and for other basic needs. She may be living somewhere where she has very little privacy. And perhaps she has experienced violence, but she hasn't told you. So I want to ask you, what do you do? Just think about what you would do if this were your patient today in your clinic with the resources you have. Would you focus only on the presenting complaint? Would you ask about where she lives, if she's safe, or how she meets her basic needs? What if there was no private consultation room in your clinic? And what if there is no GBV specialist as part of the response team? What if the referral pathways are disrupted? And what if the treatment she needs is really time sensitive? This is where protection becomes part of RMNH care. Next slide. So the presence or absence of a functioning GBV response system should not determine whether you can provide first-line survivor care. You can recognize the signs, you can listen, you can provide compassionate first-line support and deliver the clinical care that is needed. What may be complicated, in particular at an onset of an emergency, is what comes next. The referral pathways, as I said, may not be functioning. There might be no psychologist. There may be no safe shelter or protection services. There may be no private examination room, and yet the woman is in front of you. So what do you do? Suela will go into more details, and we heard more details before, so I am not going to dive into those details, but I would like to divide it into 4 things which I think are really important. Recognize, respond, treat, and connect. The first 3 are fundamentally within the clinician role. Connect is where the availability or absence of specialized GBV and protection services become particularly important. So recognize is look beyond the presenting complaint. A woman who has experienced violence may not tell you that she has been raped. She may come because of pain, pregnancy concerns, an STI, and anxiety, or simply because she needs care. So you may be the first person to notice that something is wrong without her telling you. Response means, the whole CMR, listen, believe her, do not judge her, provide first-line support using lives. How you respond to a disclosure can determine whether that woman ever seeks help again. Treat, obvious. You need to provide the time-sensitive clinical care that should not be delayed, waiting for the health system to recover. And finally, connect. A survivor may need much more than immediate first-line medical care. She may need other health interventions, even SRH, other SRH intervention, mental health intervention, obviously, protection, livelihood support. Those services may be fragmented or difficult to reach. It means asking, what is the safest and most realistic support that this woman can actually access? Not necessarily the perfect referral pathways, but the safest available option. And that ultimately is one of the roles of the RMNH provider in an emergency: to recognize, to respond, to treat, to connect, even when the system around them is disrupted. I will hand over now to Suela, who will take us through the clinical response.
Thank you very much, Nadine. maybe if we just take a moment, we are talking about climate crisis now and how clinical management of rape looks like during a crisis. But if we just step out of the crisis and even look in our normal settings, we still have so many challenges and gaps on clinical management of rape. So even as we talk about how we implement life-saving clinical management of rape in a crisis, we should be cognizant that we are already working with fragile health systems. We're already working with a lot of challenges that we continue to face day to day, not only in the health system, but also with culture of silence that surrounds talking about sexual violence and accessing care, the stigma that comes with it, and so forth. So it's really a sensitive and complex issue that we are trying to look at today. And hopefully, as we remove the layers and try to give some solutions and adaptability, we should always recognize that we still have a long way to go when it comes to clinical management of rape. So in crisis, clinical management of rape is part of the SRH minimum initial service package. And this mainly the priority SRH implementations or interventions that need to be implemented within the very first days of the emergency response. So we have many objectives in the MISP, but objective 2 is about prevention of sexual violence and responding to the needs of the survivors. We know that sexual violence will not wait during emergencies, and that it's going to be intensifying the existing violence that was there or creating more risks for the communities in terms of increasing the risk to sexual violence and intimate partner violence. So we must ensure that clinical management of rape is available right from the beginning of the emergency response, and it should be our priority from day one. I'm mentioning this because I know clinical management of rape is, again, as I say, it's complex. And many a times people would rather not do it, either based on the medical legal linkages that come with it or based on many other things that maybe today is not the day to look at that. We have several adaptations that can be made, however, with frontline clinical management of rape care that have already been mentioned by the previous speaker. So I will not go into the details of why we need to give empiric STI treatments or emergency contraceptives or PEP or whatever that we need to give for the survivors. But we need to recognize that if we need to make sure that the healthcare providers are aware of these adaptations so that they're able to provide them during the crisis. And I can also not stress, I continue to stress on ensuring that first line response is given, because there are also so many times during emergency response, we hear from healthcare providers that we don't have supplies, we don't have private areas, or we don't have so many things, especially as the emergency is in the acute period, that the healthcare providers feel inefficient to providing care. So what we need to preach, if I may use the word preach, is to ensure that the minimum that we're able to give to our survivors is the first line response. That is, giving the emotional and physical, responding to the woman's emotional and physical safety to ensure that the survivors that present to us do not undergo further harm, and that we help them to come up with a safety plan. This is the very minimum that we can give to survivors. And in the issue of screening, it's very important that we observe some prerequisites in the screening. I from UNFPA, and also from WHO, of course, universal screening is not recommended and may end up being harmful to survivors presenting in the different areas that we operate. Therefore, we do have some specific signs and symptoms that we do look out for when we receive maybe clients at that time. Maybe they are not yet survivors because we don't know. So when they present to us, we do have some specific signs and symptoms that make us have, an alert that this could be potentially a survivor of IPV or sexual violence. And then when we identify those, then we take the person in front of us through the process of the identification and provision of the first line support. So this is very, very, I think is important to highlight that, because sometimes we might think we're doing good and it ends up causing further harm rather than providing what the woman or the girl or the survivor in front of us needs from us. So we continue, despite the challenges that we have, we do continue to promote that we ensure we have the minimum requirements in existence before asking about intimate partner violence. Again, this has been because there have been several evidence to show that there are clinicians that may do more harm than good if we don't have these minimum requirements in place. So just ensuring that we know or we are aware of a protocol or a standard operating procedure on how to handle cases of gender-based violence, sexual violence, or intimate partner violence. And then those who are going to be asking should also have some training on how to ask, because a clinician, again, may ask in a way that is judgmental or in a way that causes further harm, that makes the survivor not want to proceed with the discussion, or ask the questions and then not know what to provide, thinking that I don't have the PEP right now, I don't have this right now, so what next? So it's not only about training on asking whether someone is undergoing intimate partner violence, but to ensure that after asking, we know what to do, and the minimum we can offer is the first line response, which is lives that has already been previously explained. Then the issue of private setting, again, we have to ensure that we are adapting to the different crises that is in front of us at that point, to ensure that we are providing this minimum privacy for the survivor. We all know, as in the GBV guiding principles, we have confidentiality as a core principles and respecting the survivors and so forth. So how do we adapt to ensure that we, even in the crisis settings, we are providing this audiovisual privacy that we keep talking about? So we come up with measures like temporary clinics using tents. We have mobile health units. We have sometimes using traditional tukul or areas that women suggest as private or safe areas to discuss. And I've even seen in some countries, you'll see that most of this is happening maybe in the ANC clinic or in the maternity area or in the family planning clinic, to ensure that we are providing that privacy. This is because we know of what also could happen to the woman in terms of increasing stigma around sexual violence, in terms of, having the perpetrators retaliating to them. So it's really, really an important aspect that we need to think about on how to provide that adaptation. And then confidentiality also needs to be ensured by our clinicians or those who are attending to the survivors. So not only teach them about confidentiality, but really ensure that if they are not observing confidentiality, what repercussions do they have to face? Like, is there a code of conduct they're signing? Is there measures that are taken if someone breaks the confidentiality of their survivors, either by not putting their records in somewhere safe or by discussing their cases with other members of the community? Because again, without trust, we may have many cases happening, but they're not coming to the facilities. So that's why I thought it's really important to highlight this as part of the core requirements that we need to put in place. Then a system for referral also needs to be in place. Unfortunately, when we look at sexual violence or intimate partner violence, we as healthcare providers are only able to offer part of what the survivor may need. There are so many other needs that the survivors would require that are beyond health. So therefore, having a system of a functional referral in place is also key. I continue to provide more information on the role of referral and service provision, because we know that also the impact of violence on women and girls is beyond, only the physical diseases or impact that they may have on their body. There is physical and mental health impact. There is economic impact. There is social consequences, and so forth. So the issue of referral, again, I continue to emphasize on that. We need to make every effort to ensure that regardless of the emergency, we are able to provide mental health and psychosocial care for our survivors to ensure that their well-being is also taken care of. Reproductive health care services, whatever the minimum initial service package promotes, these are some of the services that the survivor might need. So as previous speakers have mentioned, we need to know in advance who is providing what. That's why it's very important to also coordinate with other sectors or other units in the emergency. Child protection services, shelter or housing, legal or police or protective services, if the survivor consent, and livelihood, and so forth. Again, we should not assume that this is safe and this is not safe. We have an obligation to check in with the survivor if they feel safe, because again, many a times also, especially maybe in conflicts, it's not always that the police is the safest place to go, or the home is the safest place to go. So there is need for us to always check with the survivors. So this brings us to asking ourselves, so what can you do to increase readiness for protection risk during climate crisis? Because it seems, this thing will happen and we may not be prepared, we may not have this or that. So it calls us to really think deeply about our readiness to providing clinical management of rape services. And at UNFPA, we've lately been looking into this and came up with a certain framework that we are currently trying to implement in our country offices. And this framework of readiness, of increasing readiness, targets 6 different areas. That is coordination and partnership, emphasizing on the role of interagency and intercluster coordination for a successful response. We already know that it's not only the health cluster that provides services to survivors, but we need to work with protection cluster, we need to work with logistics and several others. So it's very key to ensure that coordination and partnership is strengthened. Even before the emergencies, we need to know who does what. And then program intervention. We need also to ensure there's integrated programming in clinical management of rape care. So ensuring that the SRH actors are working with GBV actors, working with MHPSS actors, because all these are services that the survivor who needs holistic look would need. And another thing is human resource and capacity building. Again, training of frontline healthcare providers to know how to provide clinical management of rape care, knowing the survivor-centered support and so forth. If we build the capacity before the emergency, then we are able to hit the ground running and support with quality clinical management of rape care during emergency. But majority of the times, this is not the case. And we go into emergencies and we still need to conduct like not full 5 days training, but short orientation sessions to make sure that as much as we are providing the care, we're not causing further harm to the survivors. Then looking at policies and guidelines, this is something that we can also do prior to emergencies to ensure that we have updated clinical management of rape and intimate partner violence guidelines. We also need to ensure that we have awareness on the different policies that exist, which are relevant to provision of clinical management of rape care services. For example, policies around abortion care or mandatory reporting or age of consent. All these things need to be looked at before the emergencies, because during the emergency, you might want to do something or provide a certain kind of service, and then you see that there is a discrepancy that the policies do not allow, and we need to work on policies, and simply there is no time at that point. So this is also a good area to look into before to increase our readiness. Then operations, communication, and access, ensuring that there's always a budget line or financing in protection services, of course, including clinical management of rape. We need to increase our advocacy, and as much as we know that gender-based violence will increase in emergencies, still there is need to increase our advocacy, because an earthquake happens, people are always, thinking about let's provide shelter, let's provide food, and every donor wants to do that, and no one is thinking about funding, protection or funding clinical management of rape. So we need to increase our advocacy. And then we also need to enhance humanitarian access for survivors and also service providers. Many a times we have difficulties in ensuring access to services for the survivors, based maybe on safety or based on infrastructure. And for us as UNFPA lately, we've also invested in enhancing humanitarian access to ensure that women and girls or survivors are able to reach the services that the providers are there to provide. And last but not least is supplies and logistics. Successful clinical management of rape programming requires supplies such as post-exposure prophylaxis or the rape kits. And we have also to ensure the last mile deliveries to health facilities. So this we can also be ensuring before climate crisis by knowing what stocks do we have, how do they reach, if this happens, maybe when we are doing advanced preparedness, how do we ensure that they reach the health facility? Because again, we've been in circumstances that the kits arrive in the capital, and then at the subnational level where they are needed, there is no way to transport them. So let's think more about prepositioning. Let's think more about forecasting on our supplies, and ensure that we up our game when it comes to preparedness. I think that's it from my end. We've included several resources that I'm sure the presentation will be shared, and you may have a look at the different resources that we have included. And yeah, that's it from me. Thank you very much.
Thank you, Sohaila. That was really, really informative and important. Thank you as well, Nadine. We only have a few minutes for Q&A. I have actually 2 requests because we have a lot of questions. I'm so glad this session generated a lot of questions and energy. Some of them were grouped around this idea of screening and what needs to be in place for screening and to screen safely or to identify survivors safely. Maybe if when we send out the follow-up resources, if there are any specific resources you would like to include, if you could share those, I think people would be interested. Also, Dr. Lesso, there were a lot of requests for more information about your work in Kilifi. So if there's anything to drop in the chat or anything, that would be helpful. And then lastly, I'll leave for everybody just one question that I think is kind of a big summary of a lot of things. So it's a big question, but a question about specifically in displacement contexts and after disasters, how can we specifically protect SGB survivors from stigma and retaliation when people are living close together, if it's a close-knit community? Have you seen anything that works, or do you have any suggestions? If any of the speakers want to respond to that.
I can kick it off, Lauren. The issue of retaliation and stigma really is a real issue that happens in crisis, and also, again, I said even before crisis, these are our realities that we continue to face. And in terms of retaliation, maybe I was a health worker once upon a time. I used to sit behind the desk and see survivors. And one of my worries was, when I go to court to give medical evidence, I worried first about myself as, someone who's presented there to share medical evidence to the court of law. And it bothered me a lot on how I do that safely. I remember the initial times I would say I want to present under witness protection where I would not have to say my name or show my face. But further on into my career, I realized that, it's more about what you present and how you present it, because you don't go there and say, yes, you are the one who committed this. We don't do it that way. We say what we have observed, but we cannot pinpoint and say this and this person did it. So that lifts the burden from our necks as the clinician, because we don't go there identifying who did this the violence. Then that lands on the police or the legal officers to say that. And then another thing, they're proclaiming that this is rape. We also don't do that. We go and share our information. I saw bruises, I saw this is consistent with the blunt force injury, this is consistent with this, but I don't go there and say this person has been raped. Again, the fact that I don't do that, it's it's the court of law that say this looks like it could be sexual violence, and they're the ones saying that, then also keeps the healthcare provider feeling safe and feeling, you don't have to carry that burden of, I'm the one who said this. So I did that for almost 10 years when I was working back then in my country, and there was no time I felt unsafe at any point because I've given medical evidence. And then going back to social stigma and going back to stigma around survivors, that's why I emphasized on the issue of minimum requirements on confidentiality, on privacy, because if these things are not ensured, then of course there's going to be stigma. Of course, there is going to be, isolation and so many things. As I said, these things don't only happen in crisis settings, but even in normal setting, we're still far way behind when it comes to how do we support our survivors. Maybe I'll just stop there so that others can also join in if they have more information to share. Thank you.
Okay. Thank you. Yes, I very much agree. I can unfortunately say that I have seen quite a few settings where we have put in place strong services that are we believe confidential and survivor centered, yet we do not see anyone coming to receive the services because the fear of stigma and mandatory reporting requirements is so large. And so this is really, I think we have a lot to work on as frontline providers, both the care itself and the follow up, and also the enabling environment around survivors feeling able to even come forward. So, and that's the case in every country in the world, I think. So I will leave it at that. Thank you all so much to our lecturer, Dr. Lesso, to our presenters. It has been so informative. We have about 50 questions I wish I could go through, but we'll be sharing that list to you all. And then to our attendees, we will be circulating resources and the presentations later. And we will see everyone next week. Thank you.
Thank you. Bye-bye.
Bye, everyone.